ডিয়ার পার্টিসিপেন্টস, সবাইকে আজকের প্রেগনেন্সি অ্যান্ড হার্ট ডিজিজ এই সায়েন্টিফিক সেশনে স্বাগতম। আয়োজনে যথারীতি আমরা বিডি ফিজিশিয়ানস। আজকে আমাদের মাঝে প্রেজেন্টার হিসেবে উপস্থিত আছেন একজন ইন্টারন্যাশনাল ফ্যাকাল্টি, ডক্টর শিল্পী আহমেদ, কনসালটেন্ট কার্ডিওলজিস্ট, সেকশন অফ কার্ডিওলজি, জনস হপকিন্স স্কুল অফ মেডিসিন, বেলটিমোর, ইউএসএ। যদিও ইন্টারন্যাশনাল ফ্যাকাল্টি, কিন্তু আসলে জন্মসূত্রে বাংলাদেশি। ম্যাডামের জন্ম আমাদের দেশে রংপুরে। তারপরে ম্যাডাম 1987 সালে এমবিবিএস পাশ করেন ময়মনসিংহ মেডিকেল কলেজ থেকে। 1990 সালে এমএসসি ইন মেডিকেল মাইক্রোবায়োলজি ডিগ্রিটি করেন লন্ডন ইউনিভার্সিটি ইউকে থেকে। In 1992 she achieved ECFMG certification. In 1992 board certification of internal medicine, American Board of Internal Medicine. In 2001 and 2012 board certification in cardiovascular diseases, AM Board of Internal Medicine. In 2009 board certification in nuclear cardiology. এছাড়াও ম্যাডাম পৃথিবীর বিভিন্ন বিখ্যাত ইনস্টিটিউটে ম্যাডাম কাজ করেছেন। আমি আর কথা না বাড়িয়ে আমাদের মাঝে আজকে চেয়ারপারসনকে পরিচয় করে দিই। আমাদের চেয়ারপারসন প্রফেসর কোহিনুর বেগম। প্রফেসর কোহিনুর বেগম বাংলাদেশে অবস্টেট্রিক্স অ্যান্ড গাইনোকোলজি ফিল্ডের একজন কিংবদন্তি। প্রথমে ম্যাডামকে কংগ্রেচুলেট করতে হবে। ম্যাডাম রিসেন্টলি বাংলাদেশ কলেজ অফ ফিজিশিয়ানস অ্যান্ড সার্জনস এর ভাইস প্রেসিডেন্ট নির্বাচিত হয়েছেন, এই জন্য ম্যাডামকে কংগ্রেচুলেশন। এবং ম্যাডাম বাংলাদেশের বিভিন্ন মেডিকেল কলেজ গুলোতে অত্যন্ত সুনামের সঙ্গে ম্যাডামের দায়িত্ব পালন করেছেন। ম্যাডাম ওজিএসবির প্রেসিডেন্টের পদ অলঙ্কৃত করেছেন। তো আমি আর কথা না বাড়িয়ে আমাদের আজকের চেয়ারপারসন প্রফেসর কোহিনুর বেগম ম্যাডামকে আমাদের আজকের সেশন প্রেগনেন্সি অ্যান্ড হার্ট ডিজিজ সেশনটি শুরু করার জন্য আহ্বান জানাচ্ছি। প্রফেসর কোহিনুর বেগম ম্যাডাম।
তোমাকে ইহসান, তোমাকে ধন্যবাদ। আজকের টপিকটা সত্যি গুরুত্বপূর্ণ ইন ওয়ান সেন্স যে মেডিকেল ডিসঅর্ডার যতগুলি আছে এটা প্রেগনেন্সির সঙ্গে ওতপ্রোতভাবে জড়িত। এর মধ্যে হার্ট ডিজিজ একটা ভালো পার্ট প্লে করে। আরো একটা কারণ কি যে প্রথম দিকে বোঝা যায় না যে এটা হার্ট ডিজিজ, মনে হবে যে সাধারণ সমস্যা প্রেগনেন্সি, কিন্তু পরে দেখা গেল তার হার্ট ডিজিজ। এটা একটা ভেরি ইম্পর্টেন্ট জিনিস। আমাদের ফ্যাকাল্টি ডক্টর শিল্পী, উনি যথেষ্ট এক্সপেরিয়েন্সড ইন দিস ফিল্ড। আমি আশা করি আমাদের সেশনটা খুব কাজে লাগবে সব আমাদের ডাক্তারদের। সো আমি এখন ডক্টর শিল্পী আমাকে অনুরোধ করব তার প্রেজেন্টেশনটা শুরু করার জন্য। ডক্টর শিল্পী, থ্যাংক ইউ।
Thank you, Dr. Begum. It is a pleasure for me to be here, and I would like to thank the Bangladesh physicians for inviting me to participate in this program. I know it's pretty late, that 9 o'clock. I'm here in Baltimore, Maryland, and it's just 11 a.m. in the morning. So without further ado, let us begin. Pregnancy and heart disease. This is a very important topic because of the comorbidities that are associated with having heart disease and pregnancy. About 0.2 to 4% of all pregnancies in the Western countries are complicated by some cardiovascular disease, and this number is increasing. The reason the number is increasing is because here women are older now when they are having babies, and they also have many other comorbidities such as high blood pressure, diabetes going into pregnancy. So consideration of management should be given to both the mother and the fetus. Therapy for the mother may be detrimental to the fetus, and therapy for the fetus may result in a suboptimal outcome for the mother. So it's very important that the therapy we utilize will be beneficial and not detrimental to either the mother or the baby. So there are no prospective or randomized trials, and recommendations correspond to the evidence level C. So there's never been any randomized trials in pregnant women as as to do this particular management or not. Counseling and management should begin really before the pregnancy occurs. So we should be having pre-pregnancy counseling for women who want to get pregnant, who have conditions which will cause them to be at a higher risk throughout their pregnancy. So pre-pregnancy counseling could be done through their OBGYN or through their primary care physicians. And this is the most important time to pick up things such as diabetes, high blood pressure, valvular heart disease, things that will adversely affect their pregnancy. Management should really be interdisciplinary team, where not just the OB, but the cardiologist, maybe an endocrinologist, the primary care physician, are all involved in taking care of the pregnant woman. If the pregnancy is considered to be high risk, then the patient should be referred to a specialized center which deals with high-risk pregnancies if it is available. This is a rather useful chart here where we are risk scoring patients who are going to have adverse events in pregnancy. And it comes from the CARPEC study. So we, first of all, when we sit with a pregnant woman, we take a good history. We listen to the patient regarding any cardiac events that have occurred prior to the pregnancy. Did they have a heart attack? Were they having rhythm problems? Did they feel palpitations? Were they ever in heart failure? Did they ever notice that their exercise capacity is decreased? They can't do as much as they used to do before. So we also figure out what their baseline functional class is. Is it class 3 or 4? These people are going to have a higher adverse event in pregnancy. So if you're in New York Heart Association functional class 3 and 4, that means that you are having symptoms with minimum or no exercise. So that's a very advanced case of heart failure. And were there any cardiac interventions prior to the pregnancy? So this we will find out in their history. So sitting down and talking and looking at their previous history and trying to see what their functional start is going into pregnancy is very important. The other thing is physical examination. Are you hearing a murmur? Is this murmur of aortic stenosis? Is it a murmur of mitral regurgitation? Or is there, is the patient cyanotic? Because this is a very important problem. Cyanosis with oxygen saturation less than 90% at rest, again, indicates that the patient may have a very adverse events during her pregnancy. Does the... I didn't catch that. Try tapping a... Sorry, on my phone. I just have to turn my phone off. I apologize. No need. So the other things are, does the patient have a mechanical valve, history of coronary artery disease, or is there high risk aortopathy? So that means, does the patient have a known history of bicuspid aortic valve? If the patient does have a bicuspid aortic valve, does the patient have an aortic aneurysm? Because during pregnancy, aortic aneurysm, it would be at a high risk of rupture. So those are specific lesions that you're going to look for. You can have, has the patient had any imaging done? The imaging that we will look for would be to see if the patient has any systemic ventricular dysfunction. Is there high risk left-sided lesions? So left-sided lesions being aortic stenosis, mitral regurgitation. What is the degree of aortic stenosis and mitral regurgitation? Do they have pulmonary hypertension? So these are things that we can find through echoes and other modalities. And when did the patient come to you for their first antenatal visit? So if the patient is already having these problems and they're arriving to you at a very late time, then again, you may have missed the opportunity to implement management at an early stage in the pregnancy. So there are also other variables, such as rare or understudied cardiac conditions, other maternal comorbidities, such as advanced maternal age, which we are now seeing, hypertension, obesity, diabetes. Are they on any medications? And one of the main problems we have with pregnancy and medications is our anticoagulants and how to manage patients who are on anticoagulants. And if they are on anticoagulants, what are the problems that the patient will face and also her fetus? Were other cardiopulmonary testing done? Fertility therapy in itself gives you a higher adverse outcome for the fetus and mother. Is the patient compliant? This is important. If the patient is non-compliant, then some of the things that we are going to advise the patient will not do will put her at risk, as well as her baby. And does the patient have access to care? And can they afford the care? And what is the quality of care that can be provided for them as well? And this will vary in different communities. Just going to go into a little bit about the epidemiology. So the spectrum of cardiovascular disease is changing, and it varies from country to country. In the Western world, the risk has increased and is now a major cause of maternal death. It's because we are now seeing increased age at first pregnancy. Women are actually having later pregnancies, even 35 and above, 40-year-old may be having her first pregnancy. There's increased prevalence of cardiovascular risks in the population now, such as diabetes, hypertension, obesity, and also a thing to remember that women who have congenital heart disease are living longer and into childbearing age because the treatment for congenital heart disease has improved. So hypertension accounts for 6 to 8% of all pregnancy-related complications. And cardiomyopathy, although rare, is an important entity, and we must never forget peripartum cardiomyopathy, and this has to be recognized during pregnancy and early delivery. So what happens when you are pregnant? The changes that take place is to meet the metabolic demands of the mother and the fetus. So we have increased blood volume, cardiac output, and the reduction in the systemic vascular resistance and thus blood pressure. So when there is an increase in the plasma volume, and this reaches about 40% above baseline at 24 weeks of gestation. Same time, cardiac output increases by 35 to 50%. And in the first part of pregnancy, it's usually due to increased stroke volume, but late in pregnancy, it is due to heart rate increase. The heart rate starts to increase at 20 weeks and continues to 32 weeks. It then remains high for up to 2 to 5 days after pregnancy. This is important because I see a lot of patients who come to me with palpitations. They feel that early on in their pregnancy. They're obviously concerned because they've never had them before pregnancy. It's usually just sinus tachycardia. Women may also have PVCs or premature ventricular complexes or premature atrial complexes. It's pretty normal to see this. They just need reassurance that it will resolve after they have developed. So the heart rate can remain high up to 2 to 5 days after pregnancy. It usually does not need any treatment at all. Then the systemic blood pressure falls early in gestation, and then the diastolic blood pressure falls in the second trimester. And this is usually due to increase in vasodilators such as prostacyclin and nitric oxide. There's also an increase in the size of the heart by about 30% due to dilatation. So one of the most important things that we have to talk about is increased thromboembolic events that may occur. There's hypercoagulability, and this is due to an increased concentration of coagulation factors such as fibrinogen and platelet adhesives, and decrease in fibrinolysis. And also there's obstruction in venous return. So we have to watch out for these women getting DVTs. So the hemodynamic changes that occur, they affect the absorption, excretion, and bioavailability of drugs. Because we have now got an increased intervascular volume, that means that there is the distribution of drugs is increased. There's an increased renal perfusion and hepatic metabolism, and this results in increased drug clearance. And drug effects and levels have to be monitored because of this reason. So significant hemodynamic changes occur during and in postpartum when the uterus contracts, the position the uterus is in. So if the patient is in the left lateral position versus supine position, you're going to have changes. Pain, anxiety, and exertion will also have the hemodynamic changes. So other stresses that the woman will be subjected to will be anesthesia, analgesia, hemorrhage, and infection. So these all have a certain amount of adverse effects on the fetus as well as on the mother. So contractions cause increase in systolic as well as diastolic blood pressure by 15 to 20% and 10 to 15% respectively. The rise in amniotic fluid, there's a rise in amniotic fluid pressure, intrathoracic pressure, venous, cerebrospinal, and extradural pressures occur during contractions. The cardiac output increases by 15% in early labor, 25% in the second stage, 50% at expulsive stage, and 80% in early postpartum. So we can see how much an effect labor has on the cardiac output. It is very significant. So I'm going to talk about a few of the major problems as a cardiologist we face when a woman becomes pregnant. First, I want to talk about a little bit about valvular heart disease. And we know that stenotic valve disease carries a higher risk than regurgitant lesions. So aortic stenosis, mitral stenosis will have a higher risk than aortic regurgitation or mitral regurgitation. The left-sided valvular diseases have a higher complication rate than the right side. And there are also those women who are coming to you because they've already had mechanical valves placed and they're on anticoagulant therapy, and there are problems associated with that to the fetus. So we'll start off with mitral stenosis. So the mitral stenosis could be mild, moderate, or severe. So moderate to severe mitral stenosis is poorly tolerated in pregnancy. And mitral stenosis accounts for most of the morbidity and mortality of rheumatic heart disease during pregnancy. And this is something probably that we see more in Bangladesh than we do here in the States. So the gradient and the pulmonary artery pressure, that's the gradient across the mitral valve, and the pulmonary artery pressure do not directly reflect the severity of the mitral stenosis, but does have a prognostic value. So the assessment of the anatomy and quantification of associated regurgitation or other valve disease must be done. So you may have mitral stenosis, but you may also have aortic regurgitation, or you may have mitral as well as aortic stenosis. So you have to find out what the anatomy of the patient is and quantify whether it's mild, moderate, or severe. Sometimes exercise testing is done to see if the patient is really asymptomatic or is having symptoms. And we also try and assess the exercise tolerance. Ideally, you should be talking to the patient and finding out those women who are going to be at a higher risk prior to her getting pregnant, and hopefully overcoming the mitral stenosis and fixing the problem before she does get pregnant. So heart failure is the main problem, and it occurs frequently with moderate to severe mitral stenosis, with the valve area being less than 1.5 centimeters squared. We see this mostly in the second or third trimester, and it is often progressive. The problem is, as Professor Begum pointed out, some of the symptoms that a woman has during pregnancy will also mimic mitral stenosis. So they're having shortness of breath, they're having exercise tolerance is decreased. So these are some of the features that you'll also see in mitral stenosis. So pulmonary edema can occur, especially if the patient goes into atrial fibrillation, or that the patient has been in atrial fibrillation, but the rate is not well controlled. Atrial fibrillation is rare, but it carries an extra risk of thromboembolic events. Mortality is between 0 to 3%. And atrial fibrillation may precipitate symptoms in women who have mild mitral stenosis, but they can usually tolerate these symptoms, and it is not usually severe. So the obstetric complications are related to acute heart failure, which can occur during or just after delivery. And this depends upon the symptoms and also the PA pressure which has occurred during pregnancy. To the fetus, there's premature rates up to 20 to 30%. There's intrauterine growth retardation occurs about 5 to 10%. Stillbirth, unfortunately, occurs in 1 to 3%. And the offspring is at a higher risk in women who have New York Heart Association class 3 and 4. So that you have things like, as I said, intrauterine growth retardations, small weight babies, and stillbirths. So how do we manage these people? Obviously, we'd like to identify and treat these women before they fall pregnant. However, moderate to severe patients, moderate to severe mitral stenotic patients should be counseled against pregnancy because the risk is so high, not only to themselves, but also to the baby. If necessary, intervention should be performed pre-pregnancy. And whenever possible, percutaneous intervention should be performed. If you do follow a patient with mitral stenosis, you should follow them monthly or bi-monthly with clinical examinations, and echocardiography should be done if you find that there is worsening of symptoms. If the patient has mild stenosis, then evaluation every trimester and prior to delivery should be enough. But again, how often you will follow your patients will depend upon how symptomatic the patients are and what degree of stenosis the valve is. So mild stenosis, you can follow them every trimester if the patient is healthy without any symptoms. But if it's moderate to severe, then you would probably need to follow them much more closely. So patients who are symptomatic or have pulmonary hypertension where the PA pressure is greater than 50 millimeters of mercury, their activity should be restricted, probably bed rest, no hard, strenuous work, not even light household duties. You should start a beta-1 selective beta blocker. And if the patient has symptoms and you see that they're going into heart failure, then diuretic should also be started. And if the patient is already in atrial fibrillation or has just newly developed atrial fibrillation, then you have to think about therapeutic anticoagulation because of the risk of strokes and other thromboembolic events. So what are the interventions that can be done in somebody who's symptomatic, has New York class 3 or 4 functional status, and there's no contraindication? You'd prefer to do a percutaneous mitral commissurotomy after 20 weeks. This should be performed by an experienced operator with abdominal shielding. Radiation dose should be minimized. You should not be doing this on asymptomatic patients at all. If you cannot do this, then a closed commissurotomy is an alternative, and this is only reserved when all other measures have failed. So during delivery, you can deliver mild or moderate to severe mitral stenotic patients if they're not having any symptoms and don't meet the other criteria. You should consider a vaginal delivery. A C-section should be considered in any patient who has moderate to severe mitral stenosis in New York Heart Association function class 3 and 4, pulmonary hypertension in whom percutaneous intervention cannot be performed or has failed. So even if they're mild or moderate to severe mitral stenosis that do not have symptoms can undergo vaginal delivery. But I would suggest that these women should always deliver in a place where they can be quickly sent to surgery if needed at the time of delivery. So we'll move on to aortic stenosis. Echocardiography is mandatory for the diagnosis of the degree of stenosis that the patient has. Exercise stress testing prior to pregnancy is to make sure that they're not symptomatic, that they're not dropping their blood pressure and they don't have symptoms. What is their exercise capacity? This will all help us in aiding their management through pregnancy. So you need to assess blood pressure tolerance, arrhythmias, and the need for intervention or not. The other thing is that we often see women have bicuspid aortic valves. These can become stenotic at an earlier age, but the main problem with the bicuspid valves is that you can have aortic aneurysms or dilatation. And that is very important because pregnant women will be at a higher risk of rupture of the aneurysm. So the aortic diameter should be measured carefully and followed through pregnancy. So the cardiac morbidity is really related to the severity of the aortic stenosis and the symptoms. Asymptomatic and moderate aortic stenosis with a valve area around about more than 1 centimeter squared is well tolerated. Severe aortic stenosis is also tolerated if asymptomatic, and that there is normal blood pressure response during exercise testing. So that is why it is important to have these women, before they fall pregnant, to undergo an exercise stress test to really confirm that they're not having symptoms and they're not dropping blood pressure. So increase in the cardiac output. Remember we talked earlier that there's a significant increase in cardiac output throughout pregnancy, and over 80% during delivery, leads to an increase in the gradient across the valve. Heart failure occurs in about 10% with severe aortic stenosis. Arrhythmias, including atrial fibrillation or flutter, occurs in 3 to 25% of patients. And mortality is fair if you carefully manage these patients throughout their pregnancy. And always remember that pregnant women with bicuspid aortic valves have the added risk of aortic dilatation and dissection. What is the effect of severe aortic stenosis on the baby, on the fetus? So you can have preterm birth, intrauterine growth retardation, and low birth weight. So how do we manage these women? First of all, we have to counsel these women before they become pregnant. So all symptomatic patients with severe aortic stenosis should again be counseled not to fall pregnant or to undergo intervention prior to falling pregnant. Asymptomatic patients with impaired LV function, these are also a group of patients to be counseled against pregnancy. And those patients that you put on the treadmill who have a pathological stress test, they should be counseled against pregnancy. So any arrhythmias developing during the stress test, dropping blood pressure, not very good exercise capacity, or having symptoms of chest pain, shortness of breath, these women should again be counseled against getting pregnant. If pregnancy is desired, then valvuloplasty or surgery should be performed pre-pregnancy. So we are trying to avoid the adverse effects of all these stenotic lesions by fixing the problem before they get pregnant. So the management of aortic stenosis through pregnancy is restricted activities are indicated for all patients who develop signs and symptoms of heart failure. So you have to bring them in and you have to examine them and you have to decide whether they are becoming pregnant, becoming symptomatic or not. So again, talking to your patients is very important, asking them, what can you do now? Are you still able to do your household chores? Are you able to walk? Can you climb up a flight of steps comfortably? So you have to have some markers that you are going to follow throughout their pregnancy. Use of diuretics, beta blocker or non-dihydropirid and calcium channel blockers should be considered for rate control in atrial fibrillation, and digoxin if all fails. What are the interventions that we may need to do? If the patient is severely symptomatic and not responding to medical therapy and the aortic valve is non-calcified, that means it looks as though you can do a valvuloplasty, and there is, then that should be done. But always remember that some of these valves also have regurgitation. So the regurgitation through the valve has to be minimal, because when you are doing a valvuloplasty, you are actually exchanging one problem for another problem. You're exchanging aortic stenosis for regurgitation. So if the patient has minimal regurgitation, you might make it into a moderate regurgitation. So it's very important to understand that not all valves can go under valvuloplasty. If this is not possible and the condition is life-threatening, then early valve replacement should be considered just after or early after cesarean section is performed. They should not undergo vaginal delivery. So cesarean section in severe aortic stenosis, particularly with symptoms during the second half of the pregnancy, should be performed with endotracheal intubation and general anesthesia. Avoid hypotension during regional anesthesia and analgesia. This is very important. If people become hypotensive, then that is like a spiral down to a very bad outcome, which is death. So moving on to mitral and aortic regurgitation. As we noted before during the pathophysiology, that there is decreased vascular resistance during pregnancy, which reduces regurgitant volume. So women who have mitral or aortic regurgitation actually tolerate pregnancy better, and their regurgitation may actually decrease. So the only thing to note is that severe regurgitation with left ventricular dysfunction is poorly tolerated. And acute regurgitation, that's something that occurs due to, say, a papillary muscle rupture, is very poorly tolerated. Most women who are coming into pregnancy with mitral and aortic regurgitation have had it for some time. So their volume status will be a little different from the acute regurgitations. So the ascending aortic diameter should be measured with women with severe aortic regurgitation, especially those with bicuspid aortic valves, because here we're looking for aortic dilatation and aneurysms, which can cause aortic dissection in pregnancy. So what is the maternal risk? Well, this really depends upon the regurgitation severity, the symptoms, and the left ventricular function. Those who have severe regurgitation and symptoms and compromised left ventricular function are at a higher risk of heart failure. There is usually no increased obstetric complications, but the offspring complication is increased in symptomatic regurgitation, so preterm, low weight complications can occur. And how do we manage these women? Well, severe regurgitation and or symptoms of compromise with left ventricular dysfunction and dilatation should all be referred pre-pregnancy surgery, hoping that they can have their valve repaired so they don't get replaced by, say, a mechanical valve, which will then cause us to now think about anticoagulation. The follow-up is required every trimester in mild to moderate regurgitation. And also you need to know if they're having symptoms or not. And severe regurgitation more often. And again, the plan of follow-up is to be individualized according to the clinical status of the patient and the symptoms. So if symptoms of fluid overload can be managed medically with diuretics, and if the patient is in atrial fibrillation, rate control with beta blockers. If the patient is having refractory heart failure, you know, you can't avoid surgery, so you may have to send them to surgery. Delivery, vaginal delivery is preferable, and epidural anesthesia and shortened second stage of delivery is advisable here as well. So moving along to those patients who are going to come to you with a mechanical valve who are on anticoagulation. So women with well-functioning mechanical valves tolerate pregnancy very well. The need for anticoagulation raises specific concern because there's increased risk of valve thrombosis, as we talked earlier, that you become hypercoagulable in pregnancy. There's hemorrhagic complications, and there's complication to the offsprings as well. The risk of valve thrombosis is increased during pregnancy. It's about 3.9% with oral anticoagulants throughout pregnancy, and 99.2% when unfractionated heparin is used in the first trimester, and oral anticoagulants are used in the second and third trimester. 33% with unfractionated heparin throughout pregnancy. The use of oral anticoagulants in pregnancy is such that you have to have strict INR control, and this is the safest regimen for the mother. There's actually no superiority of either unfractionated heparin or low molecular weight heparin in the first trimester, and this has been unproven. There's no superiority over either of them. What is the risk? What's the obstructed and offspring risk? There's increased risk of miscarriage, hemorrhagic complications, especially bleeding into the placenta, which can lead to premature birth and death, and embryopathy in 0.6 to 10% of cases when you use oral anticoagulants. Unfractionated heparin and low molecular weight heparin do not cross the placenta and do not cause embryopathy. If you're using warfarin and the dose is less than 5 milligrams, this resulted in only 2.6%, and a greater dose of, if you're using more than 5 milligrams, this results in 8% incidence of embryopathy. So you can see if you can use warfarin to maintain an INR with just 5 milligrams, you're better off using that dose. Continuation of oral anticoagulants throughout pregnancy should be considered when the warfarin dose requirement is less than 5 milligrams daily. So this is important. So if you can maintain an INR which is acceptable, and you're using just 5 milligrams, and you can use that throughout the pregnancy. Discontinuation of oral anticoagulation between weeks 6 and 12, and you replace that by a dose-adjusted unfractionated heparin and low molecular weight heparin daily, should be considered in patients with a warfarin dose more than 5 milligrams per day. So you use, I hope that's understandable. So during the delivery, you should switch to heparin prior to delivery, and planned C-section may be considered in high-risk patients with the risk of valve thrombosis, so that the time off of oral anticoagulation is kept as low as possible. And C-section should be performed if the patient is on oral anticoagulation. I think this is one entity which is very important and sometimes is missed, because the symptoms of peripartum cardiomyopathy mimic so much pregnancy symptoms, especially towards the end of the along the third trimester. So you have to always consider this when you are evaluating patients in the third trimester who are coming in with shortness of breath and maybe decrease in their exercise capacity, and they have a lower extremity edema as well. So postpartum cardiomyopathy is an idiopathic cardiomyopathy presenting with heart failure secondary to left ventricular systolic dysfunction towards the end of pregnancy and in the early months following delivery. It is a diagnosis of exclusion when no other causes of heart failure is found, and it is usually when the ejection fraction is less than 45%. And signs and symptoms are often typical of heart failure. They can present with acute heart failure, and we often see complex ventricular arrhythmias, and sudden cardiac arrest has also been described in these patients. The guidelines for management is the guidelines of acute heart failure. Now, so that would be diuretics, mainstay of treatment there. Prognosis of postpartum cardiomyopathy is very different from a dilated cardiomyopathy due to other causes, as there is a significant improvement or normalization of the left ventricular function over the first 6 months after diagnosis. Now, there's relatively high, greater than 50% spontaneous recovery of the left ventricular function. So the things to remember is that there are adverse effects of drugs on the fetus, and we must take into consideration. We may have to do urgent delivery irrespective of the time of gestation, and it may be necessary because the woman presenting may be at high risk of advanced heart failure with hemodynamic instability. That's the only way that you're going to save the mother. Once post-delivery bleeding has stopped, anticoagulation should be considered in these patients because of the very low ejection fractions may cause them to be at high risk of a thromboembolic event. During the pregnancy, ACE inhibitors, ARBs, and renal inhibitors are contraindicated because of toxicity to the fetus. When ACE inhibitors are needed in breastfeeding women who have peripartum cardiomyopathy, then benazepril, captopril, or enalapril are preferred. Second line of treatment could be hydralazine and nitrates. Beta-1 selective drugs such as metoprolol is usually preferred, and atenolol should not be used. Delivery, vaginal delivery is preferable if the patient is hemodynamically stable. And you have to watch these people very closely, especially if an epidural analgesia is preferred. Preterm delivery is reported in 17% of these women. And again, urgent delivery should be considered in women with advanced heart failure and hemodynamic instability, in spite of you trying to treat them. One very important thing to remember when counseling women who have peripartum cardiomyopathy, that subsequent pregnancy carries a recurrence risk of 30 to 50%. When ejection fraction has not normalized, a subsequent pregnancy should be discouraged. And even if the ejection fraction has normalized, there's still a need to counsel these women because of the high risk of recurrence with the next pregnancy. And with this, I end. Many thanks for all of you taking the time for participating in this program. I know it's pretty late out there in Bangladesh. Stay safe, mask, distance, wash hands, and self-monitor. And thank you again.
Thank you very
Thank you,
much
madam, for your extraordinary presentation. ম্যাডাম, আমি এখন আমাদের আজকের চেয়ারপারসন এবং বাংলাদেশের one of the most experienced obstetrician and gynecologist, যার লক্ষাধিক পেশেন্ট মিনিমাম দেখার এক্সপেরিয়েন্স আছে, তার বেশি হবে। আমি ম্যাডামের কাছে বাংলাদেশের অবস্থানে, বা ম্যাডাম তো প্রচুর ফেস করছেন, ম্যাডাম বাংলাদেশের বর্তমান পার্সপেক্টিভে আপনার অভিজ্ঞতা কিরকম, মানে হার্ট ডিজিজ প্রেগনেন্সির সঙ্গে এবং ম্যানেজমেন্টে আমাদের ফ্যাসিলিটি কিরকম, এই ব্যাপারে ম্যাডাম আমি আপনার কাছে কিছু শুনতে যাচ্ছি।
থ্যাংক ইউ। হার্ট ডিজিজ এখন আমি একটু আগের থেকে চিন্তা করি, যদি আগে হার্ট ডিজিজ প্রেগনেন্সি হার্ট ডিজিজ কম পাইতো সবাই, কেন কি প্রেগনেন্সি হওয়া পর্যন্ত থাকতোই তো না, প্রেগনেন্সি হওয়া পর্যন্ত তারা টিকতোই না, বিকজ ট্রিটমেন্ট ভালো ছিল না। কিন্তু এখন প্রেগনেন্সি উইথ হার্ট ডিজিজ, যে কোনো ধরনের কনজেনিটাল হার্ট ডিজিজ বলো, অ্যাওর্টিক অ্যাকোয়ার্ড হার্ট ডিজিজ, সেগুলি ভালো ট্রিটমেন্ট শুরু হওয়াতে এখন প্রেগনেন্সি নিয়ে মায়েরা আমাদের কাছে বেশি আসে, আগে আসতো না। কাজে এটা একটা ইম্পর্টেন্ট জিনিস। তাহলে ধরনটা একটু বদল হয়েছে, এই ইন ওয়ান সেন্স যে এখন কনজেনিটাল হার্ট ডিজিজটা কিন্তু আমাদের এখন বেশ ভালো পাওয়া যাচ্ছে, অ্যাওর্টিক তো পাওয়া যাচ্ছে, বিকজ মানে ভালভুলার ডিজিজ তো পাওয়া যাচ্ছে, তবে ভালভুলার ডিজিজটা একটু কমছে। কেন কি ফর দ্য ট্রিটমেন্ট আগের থেকে যেহেতু ট্রিটমেন্ট শুরু করে, যেমন টনসিলাইটিস বা ওগুলি সব ট্রিটমেন্ট শুরু করে বিধায় রিউমেটিক হার্ট ডিজিজ বা ভালভুলার হার্ট ডিজিজ একটু কম। তো কনজেনিটাল হার্ট ডিজিজ আমাদের এখন একটা লাইমলাইটে আসছে, এটা ঠিক। তো এখন আমাদের সমস্যাটা হলো কি, যে এখানে যেমন বিদেশে যেমন তারা খুব ওয়াকিবহাল, তারা খুব ফলো আপে যায় এসে, আমাদের এখানে তো সেরকম না। প্রি প্রেগনেন্সি কোনো ফলো আপ, প্রি প্রেগনেন্সি যে একটা মানে ফলো আপ আছে বা নিতে হবে, এটা আমাদের এখানে নাই। সেই জন্য কি হয়, পেশেন্ট যখন প্রেগনেন্সি নিয়ে আমাদের কাছে আসে হার্ট ডিজিজ, আমাদের অনেক সময় ভুল হয়ে যায়, আমরা মিস্টেক করি যেটা কি নর্মাল সিমটম নাকি। যখন দেখি যে কোনোভাবেই আর নর্মাল সিমটমগুলি কাটে না, তখন আমরা পেশেন্টকে চিন্তা করি যে এটা কার্ডিয়াক ডিজিজ কিনা, সেই ক্ষেত্রে আমরা ইনভেস্টিগেশন করি, ট্রিটমেন্ট করি। তো যাই হোক, এখন সবচেয়ে ইম্পর্টেন্ট কথা হলো যে এইটা ট্রিটমেন্ট পারপাসে অবস্টেট্রিশিয়ান একলা পারবে না। দ্য অবস্টেট্রিশিয়ান শুড টেক দ্য অ্যাডভান্টেজ অফ আদার টিম মেম্বার্স। একজন কার্ডিওলজিস্ট লাগবে, একজন অ্যানেস্থেটিস্ট লাগবে, একজন পেডিয়াট্রিশিয়ান লাগবে। অলসো রোগীদেরও কিন্তু রেসপন্সিবিলিটি অনেক বেশি। আমি একটা গল্প দিয়ে শুরু করি। আমার একটা পেশেন্টের কার্ডিওমায়োপ্যাথি হয়েছে প্রথম প্রেগনেন্সিতে, তারপরে পেশেন্ট একদম শকে চলে গেছে, তারপরে বাধ্য হয়ে পেশেন্টটাকে আমার ডেলিভারি করে ফেলতেছে, বাচ্চাটা বাঁচে নাই। ওকে বলা হয়েছে তুমি কিন্তু প্রেগনেন্সি নিও না, কারণ তোমার কিন্তু আবার রিপিট হবে এইটা। বিশ্বাস করে 1 বছরও যায় নাই, 1টা বছরও যায় না, সে বিকাম প্রেগনেন্ট অ্যাগেইন, আবার প্রেগনেন্সি নিয়ে আসছে। তো সেই পেশেন্টটা কিন্তু আমাদের একটু পেশেন্ট কথা শুনলো না, তো কাজে পেশেন্টেরকে আমাদের বুঝিয়ে বলার একটা ব্যাপার আছে, পেশেন্টের পার্টিসিপেশন দরকার আছে। তো আমি বলি যে হার্ট ডিজিজ এখন ডায়াগনোসিস হয় ইজিলি এবং যথেষ্ট ভালো ট্রিটমেন্টও হয়। আগের চাইতে মর্টালিটি কমছে, মরবিডিটিও কমছে, বাচ্চার সার্ভাইভিলিটি অনেক বাড়ছে, যেহেতু আমাদের অনেক ভালো কার্ডিওলজিদের সঙ্গে আমাদের একটা আন্ডারস্ট্যান্ডিং আছে, আমরা ট্রিটমেন্ট করতে পারি। এ পর্যন্ত বলছি। এহসান।
ম্যাডাম থ্যাংক ইউ ম্যাডাম। আমাদের বেশ কিছু কোশ্চেন আছে, আমি আপনার অনুমতি ক্রমে ম্যাডাম একটু কোশ্চেন আনসার সেশনটা শুরু করতে যাচ্ছি।
বলো।
ম্যাডাম ফার্স্ট কোশ্চেন আমাদের আজকের স্পিকার ডাক্তার শিল্পী ম্যাডামের কাছে। ম্যাডাম, ডাক্তার সারাল রাজে একটা কোশ্চেন করেছেন ম্যাডাম, হোয়াট ইজ দ্য রোল অফ লিভোকার্নিটিন ইন দ্য কেস অফ পেরিপার্টাম কার্ডিওমায়োপ্যাথি?
আনমিউট করেন, আনমিউট। আনমিউট, হ্যাঁ। আনমিউট হচ্ছে না, হ্যাঁ হয়েছে।
I think, can you hear me now?
Yes.
Okay, good.
Yes,
don't,
yeah.
okay. Here, we don't What was, I apologize, what was the question again? What was the question?
Madam, what is the role of levocarnitin in the case of peripartum cardiomyopathy?
We don't use that much here. I do not have much experience of using levocarnitin in peripartum cardiomyopathy patients here. We don't use it. How about in Bangladesh?
Thank you, madam.
No, exactly.
No, we don't have the rule of.
Madam, next question, madam. Next question, madam. Eta ashole amader deshe use hocche. Madam, what is the indication of using aspirin in second and third trimester of pregnancy?
For what reason are you using it?
Madam, kono indication ki ache erokom aspirin use korar?
In preeclampsia, I think it's used in the third trimester of pregnancy.
No.
But we don't use it
Madam,
for like.
Madam, chat korben?
Can I comment? না রোল অফ অ্যাসপিরিন হার্ট ডিজিজ সেটা আমি বলতে পারবো না, কার্ডিওলজি ভালো বলতে পারবে। তবে আমরা অন্যান্য কারণে তোমার ইকোস্পিরিন অ্যাড করি অ্যাসপিরিন। ফর এক্সাম্পল ইন প্রিভেনশন অফ পিইটি অ্যাজ এ প্রিভেন্টিভ মেজার ফর পিইটি, যাদের আগে হাই রিস্ক গ্রুপ, যাদের আগে প্রিক্লাম্পসিয়া হয়েছে কিংবা যাদের আগে হাইপারটেনশন আছে, তাদের আমরা ফার্স্ট ট্রাইমাস্টার এন্ড অফ ফার্স্ট ট্রাইমাস্টার থেকে অ্যাসপিরিন শুরু করি 75 মিলিগ্রাম থেকে 100 মিলিগ্রাম ডোজে, সিঙ্গেল ডোজ আনটিল ডেলিভারি। নতুন সিস্টেম আনটিল ডেলিভারি ইউজ করি। আর একটা ইন্ডিকেশন আছে যাদের অ্যান্টিকার্ডিওলিপিন অথবা অ্যান্টিফসফোলিপিড অ্যান্টিবডি আছে, অ্যান্টিফসফোলিপিড সিনড্রোম, তাদের বেলায় আমরা অ্যাসপিরিন ইউজ করি অ্যাজ এ প্রিভেন্টিভ মেজার ফর ফর্মেশন অফ মাইক্রোথ্রম্বাই এট দ্য প্লাসেন্টাল বেড। এটা আমরা ইউজ করি।
I think most women who are falling pregnant are not in that group of patients who have atherosclerotic coronary artery disease. So we don't usually use aspirin in any of the conditions, except if they had underlying coronary disease, have had myocardial infarctions, have had stents placed. In that case, you can use very low dose, 81 milligrams of aspirin throughout pregnancy. But again, we don't usually see that condition in this age group of patients.
Thank you, madam. Dr. Aisha Mohammad Osmaner duita question ache, madam. The first question, why do some recovered postpartum cardiomyopathy mothers experience heart failure with a subsequent pregnancy? And her second question, what would be the choice of anticoagulant in pregnancy with pre-existing cardiac conditions, if indicated?
Okay, so for peripartum cardiomyopathy, 1/3 will recover, 1/3 will have the same heart function, and 1/3 will have improvement of their heart function. We said up to 50%. But which person this is going to be is not yet fully understood. The reason for postpartum cardiomyopathy itself, the reason why it happens is not well understood either. So if you have somebody who has had peripartum cardiomyopathy, you're not going to know which person is this going to stay stable or deteriorate. So the best thing to do, and what I advise, is after the first time this has occurred, not to fall pregnant again. It has been shown in some women post-delivery, after they have recovered, if they have a negative dobutamine stress echo, that they may maintain their heart rate, their heart function on a subsequent pregnancy. But again, this is that group of people who, the group of patients who were studied was so low, I would not recommend it. I mean, I've followed patients who have had peripartum cardiomyopathy. We've had them on heart failure treatment for at least 2 to 3 years, weaned them off the medications with following their heart functions, and it's been stable, but as we've said, subsequently don't fall pregnant again. The other question was about anticoagulation.
Madam, other question. ম্যাডাম এটা আসলে আপনাকে আরো অনেকে রিকোয়েস্ট করেছে ম্যাডাম অ্যান্টিকোয়াগুলেশন থেরাপিটা যদি ম্যাডাম আরেকটু বলেন।
Okay, so for
প্রেগন্যান্সিতে
anticoagulation,
অ্যান্টিকোয়াগুলেশন থেরাপিটা একটু।
for mechanical valves and for patients who are in who have mitral, who have atrial regurgitation or atrial flutter and require to be on anticoagulation, if they're, the best thing to do is to have them on 5 milligrams of warfarin if that maintains their INR at a therapeutic range throughout their pregnancy. If you cannot do that, then when from week 6 to 12, you will put them on an unfractionated or low molecular weight heparin and then switch to warfarin and to whatever dose they need to maintain an INR between 2 and 3 or point, whatever, for whatever reason they're on, you know, the INR will differ if they're on it for atrial fibrillation or for a mechanical aortic or a mechanical mitral valve. And then prior to delivery, you want them on heparin so that you can turn the heparin off, do the surgery, and then put them safely back on again, heparin, and then convert back to warfarin. So that is the way to do it. I hope that answers your questions. Do you have anything else to say, Professor Begum?
No, it is sometimes we have to continue the heparin in some cases. Those who have recurrent pregnancy loss due to EPA syndrome, in that case, we have to continue the low molecular heparin from first trimester to the end of delivery. But in that case, we have to take the advantage of consulting with the hematologist. Hematologist should monitor the patient till by proton midtime or something else. But in that case, this is the condition where we can have to continue this heparin throughout the whole pregnancy. Otherwise, if the heart disease, this warfarin should be given as because it is a embryopathy, it causes embryopathy.
Yes.
So it is better to avoid during the organogenesis period. After that, you can continue the warfarin. And prior to delivery, as because dose has to be strictly maintained, so it is better to go for heparin during delivery. After 48 hours, we can again switch over to warfarin.
থ্যাংক ইউ ম্যাডাম। আসলে কোশ্চেন শুধু আসছে, আমি ম্যাডাম একসাথে বেশি বেশি কোশ্চেন নিচ্ছি। টু ডক্টর শিল্পী আহমেদ ম্যাডাম, আপনার কাছে আবার আমি দুটো কোশ্চেন একসাথে করছি। ডক্টর রাফা বিনতে নূরের ফার্স্ট কোশ্চেন, টু ডিটেক্ট congenital heart disease in the unborn baby, what can we do antenatally? What should be the timing of ultrasonography in this case? Madam, first question.
The question is, how do we recognize congenital heart disease in the fetus? And what was the second one? How do we diagnose it? Well, when is the best time to do ultrasound? So again, here ultrasounds are done pretty early on in pregnancy, and usually there is one done at 4 weeks and then one done at 9 weeks, and subsequent ultrasounds are done depending on the findings at those 2 stages. There is also blood work that can be done, doing genetic studies to figure out, to see if they have any congenital diseases. So I think ultrasound is the mainstay of looking to see if there is any congenital heart disease in these in the fetuses, and they start pretty early. So if you find something, say at 9 weeks, then obviously you're going to tailor the management to that particular individual. So there's no hard and fast rule saying that it has to be done at 3-month interval or 2-month intervals, and so on. So it's all focused on that particular patient. So it's very difficult to say that it has to be done this way.
Thank you, madam. Dr. Rafa.
আমি একটু বলবো।
Dr. Rafa, next question.
Those who have congenital anomaly, those mothers who have congenital heart disease, we can do a scan at 11 to 12 weeks because there is a chance of congenital heart disease of the baby also. So it can be done at the 11-12 weeks to see the nuchal translucency. সেই তাদের বেলায় নিউক্লিয়ার ট্রান্সলুসেন্সি বাড়ে 11-12 সপ্তাহে। আর আমরা তো অ্যানোমালি স্ক্যান করি 22 থেকে 24 সপ্তাহে, তখন ধরা যায়। কিন্তু স্পেসিফিক্যালি আমরা কার্ডিয়াক অ্যানোমালি স্ক্যান করতে পারি at 24 উইকস। সেই ক্ষেত্রে যদি তখন ম্যানেজমেন্টও ডিফারেন্ট হয়ে যায়, কারণ তখন 24 উইকসে ম্যানেজমেন্ট করা তো ডিফিকাল্ট। যদি কোনো কনজেনিটাল অ্যানোমালি থাকে উই হ্যাভ টু কন্টিনিউ, কিংবা ডেলিভারি পরে ইমিডিয়েট পরপর করা যেতে পারে। তবে আর্লি ট্রাইমেস্টারে যদি অবভিয়াসলি কিছু পাওয়া যায় তখন আমাদের স্ট্যান্ট নিতে সুবিধা হয়, এই আর কি। তো কাজে আমরা আর্লি ট্রাইমেস্টারে যাদের কনজেনিটাল হার্ট ডিজিজ আছে মায়েদের, তাদের একটা স্ক্যান করে নিতে পারি, তাহলে বাচ্চাটা আর্লি বোঝা যাবে।
থ্যাংক ইউ ম্যাডাম। যেহেতু ম্যাডাম কোভিড এরা, তো কোভিড নিয়ে একটা কোশ্চেন আছে, হোয়াট এক্সট্রা প্রিকশনস শুড বি টেকেন ইন এ পেশেন্ট উইথ কার্ডিওভাস্কুলার ডিজিজ ইন প্রেগনেন্সি ইন কোভিড পজিটিভ কন্ডিশন? ডক্টর শিল্পী আহমেদ ম্যাডাম কিছু অ্যাড করুন।
So I think the question should be twofold. Twofold. One is we are going to, in women who are pregnant women should not be denied the COVID vaccine. They should be told that pregnancy is not a contraindication for COVID-19 vaccination. The risk of having COVID infection and being pregnant is very high, including loss of fetus and also major complications, including thromboembolic events, such as pulmonary emboli, DVTs. You can also have kidney failure, end up on dialysis, intubation. So the risk is so high that it can even lead to death. So women should not be discouraged from taking COVID-19 vaccination. And it's the standard treatment for any woman who has COVID, depends on how bad her symptoms are. So her symptomology and whatever she has will dictate how you're going to treat her. So there is no standard treatment. It is all dependent on what she presents with. So treatment for pneumonia, treatment for pulmonary embolism, treatment for kidney failure will all impact not only her, but the fetus. And so there will there's going to be high rate of fetal death. Early preterm babies as well will occur. So should be, I mean, we don't discourage anybody to have COVID-19 vaccination, and there's no need to get a pregnancy test prior to getting a COVID-19 vaccination. The antibodies that are produced in the mother are passed on to the fetus and will protect the baby when they're born. And even lactating women who have had vaccination will also protect her child as well.
Sometimes if the
information.
patient acquire COVID in the first trimester, if the patient having COVID in the first trimester, and according to Professor Shilpi, if he's asymptomatic, no symptom, D-dimer is normal, CRP is normal, treat as normal. But at the last trimester, the risk is in the last trimester of pregnancy, because pregnancy itself is a hypercoagulable state. And in COVID, there is formation of thrombosis. So in that case, if there is a consultation with physician, we can give her liquid, blood liquefier. We can give them at the third trimester of pregnancy.
থ্যাংক ইউ ম্যাডাম।
Flexin or something we can use at the third trimester.
ম্যাডাম একটা কোশ্চেন আসলে জাতীয় সমস্যা, এটা আমরা যারা জিপি করেছি পেরিফেরি লেভেলে বা উপজেলা লেভেলে যারা চাকরি করি, এটা সবাই ফেস করি। আর একটা মাইসাম সোভান একটা কোশ্চেন করেছেন, ম্যাডাম, many pregnant patients complaints of leg edema in later part of pregnancy. How can we manage it? আমরা অনেক জিপি কে দেখি যে ম্যাডাম ফুসেমাইড পর্যন্ত দিয়ে দেয়। এই ব্যাপারে ম্যাডাম আপনার ওপিনিয়ন শুনতে যাচ্ছি। কোহিনুর ম্যাডাম প্লিজ।
আমার ওপিনিয়ন হলো কি, যে যদি পেশেন্টে একমাত্র ওই যে আমরা যে কার্ডিয়াক সমস্যা থাকে, হার্ট ফেইলিওর থাকে, only in that case it is indicated, because সেখানে বাচ্চার কি হলো সেটা পরের বিষয়, আগে মায়ের তো হার্ট ফেলিওর চিকিৎসা করি, কিন্তু এটা ছাড়া হার্ট ফেলিওর ছাড়া ডায়াবেটিক্স দেওয়ার কোনো ইন্ডিকেশন নাই। রেদার ডায়াবেটিক্স দিলে সমস্যাটা কি হবে, হিমো কনসেন্ট্রেশন হবে, ইউট্রাসে ব্লাড সাপ্লাই কমে যাবে, বাচ্চা হাইপক্সিয়া হবে, দেয়ার ইজ চান্স অফ ডেথ। এই জন্য আমরা ডিউরিং প্রেগনেন্সি ডায়াবেটিক্স অ্যাভয়েড করি। বাট পেশেন্টের কন্ডিশন চিন্তা করে ইফ শি হ্যাড হার্ট ফেলিওর ডিউ টু কার্ডিয়াক ডিজিজ, অফকোর্স আমাদের দিতে হবে এবং যতটা ডোজ লাগে দিতে হবে টু সেভ দ্য মাদার।
Exactly. I think we have to understand that we are hoping not to get to that stage where the mother is having edema or heart failure. We will be managing these patients from, if we can pick up these patients who are going to have adverse events through their pregnancy, these are picked up earlier on, even before they're pregnant, and fix the problem before they become pregnant, then we will not see this problem. But heart failure has to be treated with standard medical therapy, goal-mediated standard therapy, including, diuretics if needed. But again, this is not just a cardiologist taking care of this pregnant woman. The cardiologist is always in having a conversation with her obstetrician as to what is the best way to manage this high-risk pregnancy. And I think the important thing to think about is that when we manage patients, pregnant women, we are not managing just one person, we are managing two people, and that all these problems have to be managed with an interdisciplinary group of people who are going to be giving you the best advice for the safety of the mother and the baby, and to have a good outcome, which is a healthy baby at the end and a mother who's also healthy. So it's a collaboration, and that's a very important thing.
Of course, it's a collaborative. ডেফিনেটলি কার্ডিওলজিস্ট সবাই নিয়ে একত্রে ট্রিটমেন্ট করতে হবে। এটা একটা সিঙ্গেল ওয়েতে ট্রিটমেন্ট করলে পেশেন্টের আউটকাম খারাপ হয়ে যাবে, বোথ মাদার এবং বেবির আউটকাম খারাপ হবে।
এক্স্যাক্টলি।
ম্যাডাম আরেকটা কোশ্চেন আছে ডক্টর কলিম মাহমুদার। ম্যাডাম, প্রেগন্যান্সি উইথ হার্ট ডিজিজ সিজারিয়ান সেকশন কে মাস্ট?
No. If you only people that you are sending to C-section are unstable patients that you have not been able to stabilize, hemodynamically unstable, where the outcome of the mother and the baby is going to be bad if you don't take action now. That's when it is. So for all the things we've looked at, aortic stenosis, regurgitation, even pulmonary peripartum cardiomyopathy, preeclampsia, anything that is going to have an adverse effect on that pregnancy, especially the mother, goes to surgery.
প্রফেসর কোহিনুর বেগম কিছু অ্যাড করবেন?
ঠিক, যদি অন্য কোনো যদি অবস্টেটিক ইন্ডিকেশন না থাকে, তাহলে হার্ট ডিজিজ ইটসেলফ ইজ নট এ ইন্ডিকেশন ফর সিজারিয়ান সেকশন আনলেস পেশেন্ট ইজ ডিকম্পেনসেটেড। পেশেন্ট কম্পেনসেটেড নাই, ট্রিটমেন্ট করে কম্পেনসেট হয় নাই পেশেন্ট, কিংবা দিনে দিনে খারাপ হয়ে যাচ্ছে, তখন যদি আমাদের আউট করতে হয় তাহলে অনলি। কিন্তু হার্ট ডিজিজ ইটসেলফ ইজ নট এ ইন্ডিকেশন ফর সিজারিয়ান সেকশন আনলেস দেয়ার ইজ আদার অবস্টেটিক ইন্ডিকেশনস।
ম্যাডাম আর একটা কোশ্চেন নিচ্ছি ম্যাডাম আমাদের চ্যাট বক্স এবং এ থেকে। ডক্টর সঞ্জিত, we use heparin in first trimester and after 36th week. Please say about it. Anyone?
Shall we repeat it again?
হ্যাঁ ঠিক আছে ম্যাডাম, তাহলে এটা আমরা একটু
না ওটা বলছি,
বললে ভালো হবে
আবার বলে দিব, অসুবিধা নেই, বলবো।
Okay, so this is a very interesting question. We always get this. Depending on the indication, so patients can come in with mechanical valves depend on the aortic position or the mitral position, and it could be due to atrial fibrillation, pulmonary emboli, DVTs, all these things. So if the patient can be managed to have an appropriate therapeutic INR with 5 milligrams of warfarin, that should be continued throughout pregnancy. If 5 milligrams or less gives you an appropriate INR, use warfarin. But between 6 and 12 weeks, unfractionated heparin or low molecular heparin can be used, and then back to warfarin. Prior to surgery for C-section, then you would switch over to heparin and use heparin because you can turn that off and do your surgery safely, and then put them back on warfarin again. Anything else, Professor Begum?
Thank you, madam.
না আবার আমরা এটা একটা জিনিস যে আমরা যখন হেপারিন ইউজ করব থার্ড ট্রাইমেস্টারে, আমরা যদি কোনো সময় সিজারিয়ান সেকশন বা অন্য সার্জারি, তাহলে অ্যাটলিস্ট 24 মিনিমাম 24 আওয়ার্স আগে হেপারিন বাদ দিতে হবে। কারণ কি তাহলে সার্জারি করার যথেষ্ট ব্লিডিং হবে, বাট ইমিডিয়েটলি পেশেন্ট স্টেবল হয়ে যাওয়ার পরে, কেউ কেউ বলে 12 আওয়ার্স, কেউ কেউ বলে 24 ঘন্টা পরে অ্যাগেইন উইল স্টার্ট আওয়ার হেপারিন। তারপরে আমরা পরবর্তীতে ওয়ারফেরিন আবার চলে যাব যখন পেশেন্ট স্টেবল হবে। কিন্তু সার্জারি ইমিডিয়েট আগে হেপারিনটা মিনিমাম 12 আওয়ার্সের জন্য বন্ধ রাখতে হবে।
And also remember that the mechanical valves, you can have normal INRs for up to 3 to 5 days even on these valves without having a significant risk of thromboembolism or thrombus forming on the valves themselves. So you do have, there is a safety net there, a time where you can take them off the anticoagulation, but you don't want to do it for too long because again, you have a woman who in pregnancy, they are more likely to form thrombus on the valves.
Thank you, madam. আপনার কাছে আসলে আরেকটা লাস্ট কোশ্চেন করতে হচ্ছে টু ডক্টর শিল্পী আহমেদ। এটার পরে ম্যাডাম এই কোশ্চেন আনসারের পরে আপনি আপনার টেক হোম মেসেজ থাকলে সেটাও দিবেন, তারপর আমরা চেয়ারপারসনের কাছে যাব কনক্লুশনের জন্য। ম্যাডাম, লাস্ট কোশ্চেন টু ইউ ফ্রম ডক্টর শারমিন আক্তার। হোয়াট ইজ দ্য এন্টিনেটাল কেয়ার শিডিউল and fetal surveillance in heart disease in pregnancy, and need of any extra investigation for mothers?
I think through this lecture, what I want to emphasize most is that heart disease in women, including valvular heart disease, or which is what we mainly see, and congenital heart disease, these things should be picked up prior to a woman getting pregnant. That is the most important thing. So that if somebody has, say, is born with a bicuspid aortic valve and has aortic aneurysm, that should have been picked up earlier than later. So that when they're coming to become pregnant, the conversation about what the risks are and what to do and what must be done before the patient falls pregnant should take place. And that's usually through somebody like the general practitioner, the regular OB who sees this person from an early age, right? From childbearing age or onwards. If they already have established disease, say like a patient comes to me and I hear a heart murmur, and I think this is aortic stenosis, at that point, I'm going to get an echocardiogram to define the aortic valve and the heart function. I'm going to do a stress test to see if the patient is symptomatic, if they have moderate to severe aortic stenosis. So these things, the way you treat these patients is very individualized. There is no cookie cutter regimen that fits everybody. Everybody has to have their own individual plan. First, I think the take-home message is talk to your patients before they become pregnant, find out what they have before they get pregnant, and fix the problem before they get pregnant. If they already have a problem, aortic stenosis, mitral stenosis, regurgitation, or any other, or congenital heart disease, at that point, they become high-risk pregnancy. You have to bring in all your other people who are going to help you manage this patient. How you manage them as a cardiologist, you have to find out the degree of regurgitation or the degree of stenosis, what is the valve area, what is the dilatation of the aortic root or the aorta, all these things. Then after you've got the information, you can decide how often you're going to see the patient, on how symptomatic they are, and so on and so forth. So I don't think you can say that this is the regimen that we're going to follow. You have to individualize care and bring in other people to help you manage this patient. It's not
thank
you
you,
by yourself.
Madam, thank you, madam. I mean, before going to our chairperson, একটা রিকোয়েস্ট ম্যাডাম, অলরেডি আমাদের আবার ফেসবুক লাইভে আছে, হাইপারটেনশন ম্যানেজমেন্ট ইন প্রেগন্যান্সি নিয়ে ম্যাডামের একটা লেকচার চাই। তো ম্যাডাম যদি কনসিডার করেন, আমরা ইন ফিউচার হয়তো বা একটা ইভেন্ট অর্গানাইজ করতে পারি।
It will be my
শিল্পী
pleasure.
আহমেদ ম্যাডামের কাছে আমাদের প্রপোজাল থাকলো।
It will be my pleasure.
থ্যাংক ইউ ম্যাডাম, তাহলে ইন ফিউচার।
Thank you very much. Again, I want to thank you all. Be safe. Be safe out there. Be very safe.
থ্যাংক ইউ ম্যাডাম। এন্ড আমি স্পেশালি আবার একটু স্মরণ করব আমাদের সবার প্রিয়, কারণ বিডি ফিজিশিয়ানসের আসলে অসম্ভব জনপ্রিয় আমাদের ডক্টর রফিক আহমেদ স্যার, যার মাধ্যমে আপনাকে আজকে আবার আমাদের মাঝে পেলাম। থ্যাংক ইউ ডক্টর রফিক আহমেদ স্যার।
খুবই পরিচিত,
স্যার আজকে আরেকটা সেশন নিয়ে বিজি।
মানুষের দেখা হয় আমাদের।
I will let you know your thanks.
আমাদের আজকের সেশন ম্যাডাম এখন শেষ করার পূর্বে আমাদের আজকের স্পিকার ডক্টর শিল্পী আহমেদকে তার আউটস্ট্যান্ডিং প্রেজেন্টেশনের জন্য ফ্রম দ্য ফ্যামিলি অফ বিডি ফিজিশিয়ানস ম্যাডামকে আমরা অন্তঃস্থল থেকে ধন্যবাদ জানাচ্ছি। এখন আমাদের আজকের সেশনটি কনক্লুড করার জন্য আমাদের বিডি ফিজিশিয়ানসের ভেরি বিগ ওয়েল উইশার প্রফেসর কোহিনুর বেগম ম্যাডামকে আহ্বান জানাচ্ছি।
আজকের সেশনটা খুবই গুরুত্বপূর্ণ সেশন ছিল এবং খুব আমাদের প্রেজেন্টার সব দিক কভার করে খুব ভালো প্রেজেন্ট করেছে। থ্যাংক ইউ ভেরি মাচ, আপনাদেরকে অসংখ্য ধন্যবাদ এইটা চুজ করার জন্য এই টপিকটা। তবে ওই লাস্টে একটা মেয়ে কোশ্চেন করছিল যে আমাদের হাউ ফ্রিকুয়েন্টলি উই হ্যাভ টু ফলো দিস পেশেন্ট, এ কথায় ডক্টর শিল্পী যে বলছে এইটাই অ্যাকর্ডিংলি করতে হবে, এটা সবার জন্য এক লাইনে ফেললে চলবে না। যেমন আমরা তো প্রথমেই পেশেন্টকে একটা ফাংশনাল গ্রেডিং করে নিব, যখন আমাদের কাছে আসবে একটা ফাংশনাল গ্রেডিং করে ফেলবো। ওই গ্রেডে যদি পরিবর্তন হয় তাহলে সাধারণ যেমন অবস্টেট্রিক পেশেন্ট দেখি সেরকম, আর যারই ফাংশনাল গ্রেডিং বদল হতে থাকবে বাড়তে থাকবে তাকেই আমাদের ফ্রিকুয়েন্টলি দেখতে হবে, তাকেই আগে হাসপাতালে ভর্তি করতে হবে। কাজে ইট ডিপেন্ডস অন। অসংখ্য ধন্যবাদ সবাইকে। এহসান তোমাকে অনেক ধন্যবাদ, ডক্টর শিল্পীকে অনেক ধন্যবাদ, বিডি আমাদের পার্টনারকে অনেক ধন্যবাদ, খুব সুন্দর একটা এর জন্য হার্ট ডিজিজ অফ প্রেগনেন্সি শেখার জন্য। আমরা ওনার কাছ থেকে আবারও নতুন কোনো টপিক শুনবো আশা করি। তো থ্যাংক ইউ ভেরি মাচ। আমার ধারণা যে এই লেকচার থেকে আমাদের ডাক্তাররা, তারপর আমাদের স্টুডেন্টরা, পোস্ট গ্রাজুয়েট ছাত্ররাও সঙ্গে আছে আমি আশা করি, তারাও অনেকটা উপকৃত হয়েছে এটা দিয়ে, এই লেকচার দিয়ে। আপনাকে অসংখ্য ধন্যবাদ। আর রফিক স্যারকে আমার সালাম দিবেন, বলবেন আমার নাম।
বলবো ইনশাআল্লাহ।